Welcome, everyone. My name is Zsolt Huszár. My PhD topic is about the risk factors of cognitive decline in elderly population. I work as a psychiatry resident at the Department of Psychiatry and Psychotherapy Clinic at the Semmelweis University. And our vision is that in the future, the cognitive decline will be avoidable by the widely used prevention programs against dementia. That's why our mission is to assist in the development of prevention programs as a part of this to identify the most significant lifestyle and biological factors of the cognitive decline. So just like any other disorders, the best treatment of dementia is prevention. Here you can overview our two projects. The first one is about that we would like to evaluate the association between pathological beta amyloid and phosphorylated tau levels and the rate of cognitive decline by our systematic review and meta-analysis. And second, we would like to estimate the relevance and the biological effects of different risk factors of major neurocognitive disorders by our observational study project. The title of our meta-analysis is investigating the association between pathological amyloid and phosphorylated tau levels and the rate of cognitive decline. And the background of our project is since 2019, the American National Institute on Aging has defined the definition of Alzheimer's disease as purely biological changes, so it's regardless of the degree of cognitive decline. The diagnostic criterion is the beta amyloid and the phosphorate tau accumulation in the central nervous system. And there are evidence that abnormal amyloid and phosphorylated tau accumulation may begin as early as decades earlier, but the extent to which the presence of these abnormalities enhance the cognitive decline is not clarified yet. So our aim is to assess the prognostic role of beta amyloid and phosphorylated tau on the progression rate of cognitive decline, which is our clinical question too. We would like to investigate two different populations, cognitively unimpaired subjects and mild cognitive impairment patients, and the exposure already mentioned two different pathological protein changes in the central nervous system, and we compare them the lack of it. And the outcome is a progression rate of cognitive decline. The clinical implication, what we hope, that we can provide more precise prognosis and we can identify the critical intervention time frames. So in the future, when we detect these pathological changes in cognitively unimpaired subjects, we will know how many years we have until the measurable cognitive decline, and that's the time period when we should start the already existing and in the future developed treatments. Here you can see our searching strategy, and here you can see our flowchart. After the application selection, we have 9,500 articles. The title of our second project is Risk Factors of Cognitive Decline in Elderly Population. It's in an observational study. The background of this, that's, as maybe you know, currently there are no effective pharmacological or non-pharmacological treatments of dementia. Our best chance is just to slow down the progression. That's why eliminating the risk factors and developing lifestyle-changing intervention programs in early stage is the current best way to prevent the dementia. And our aim is the identification of region-specific risk factors, clarifying the role of cardiovascular disease, diabetes, and late-onset depression, because these three are the most common comorbidities, and also clarifying the role of the biological factors, what we already mentioned, the pathological changes of these proteins and neuroimaging changes. The clinical question is, to what extent can the development of major neurocognitive disorders be predicted by the risk factors and biological changes? The investigated population, also the cognitively unimpaired subjects and MCI subjects, and the exposure, the different lifestyle and biological risk factors, and the outcome is the conversion to dementia. What we hope that by our study, we will be able to better estimation the risk of the cognitive decline, and by identifying the most harmful risk factors, we will be able to eliminate them. Here you can see our protocol drafting. We exclude patients aged less 50 years with any major neurological disorders. We exclude substance use patients and with reversible dementia. Our primary outcome is to converge into dementia, of course, and the secondary outcome is the rate of the cognitive decline, to identify the relationship of different risk factors and different subtypes of dementia, and to evaluate the performance of the already existing risk estimation skills in our population. Here you can overview again our two scientific projects. And thank you very much for your attention. And my quote is, az emberért megyünk mi küzdelembe, a fegyverünk tudás és szeretet. Thank you very much, and I'm happy to answer your questions.
Congratulations, fantastic. A few questions actually. So first question, you chose the outcome of rate of cognitive decline for your first project. What is the actual definition of rate of cognitive decline?
Thank you very much for your question. That's on our major topic. We have two different outcomes. The easiest is just the conversion rate to MCI, which is a mild cognitive impairment or dementia. It's based on a neuropsychological test. For example, the mini-mental state, maybe you remember, and of course, psychiatric examination. And the rate of the cognitive decline is the rate what is changed, for example, the annual rate, which is the slope of the change in a different neuropsychological tests. So we can measure the cognitive functions and we can monitoring the change of it.
The second project, how long is going to be that project?
This is an ongoing project in our psychiatric clinic. We have an outpatient clinic, a so-called memory ambulance, and the goal of it is to help to prevent dementia and to provide the best treatment. And there is a 2 years follow-up time.
Knew some people who got Alzheimer at a very young age, I mean at 50 or so, and some others get very old. So how is this? How is the time, the age relationship?
We detect, for example, is there any cerebrospinal disease or any reversible dementia, for example. So what is the age-related chance is connecting with this kind of biological